Well, hi everyone, and welcome into Pushing the Limits. Today I have a superstar for you. I have Dr. Bill Clearfield, all the way from Reno, Nevada. Welcome to the show, Dr. Bill. Fabulous to have you.
Thank you for having me.
Yeah, you have been such a major, amazing teacher to me, and you don't even know me because that's the power of YouTube. I came across your YouTube channel, which everybody has to go and follow, and I'll put the link down in the show notes. But Dr. Bill, you're a physician over in Reno, but give us a little bit of background about who you are and what you do mainly, and then we're going to dive into things like hormones and thyroids and methylene blues and all of this good stuff today.
Well, I am a successfully departed medical doctor from a regular medical doctor insurance-based practice, but I saw the light.
Saw the light, yeah.
Actually, I always saw the light. You know, it was early. In fact, I just wrote an article on 50 years as an anti-aging physician, and even when I was back in medical school, I actually spent a month. It was we had to do a month of clinical stuff at the Pritikin Clinic in Santa Monica. That was in 1977, believe it or not.
Wow.
And it was like the first inklings of low-fat diets, which turned out to be not such a great thing, but you know, it was strictly for heart disease. It was, you know, the treatment for heart disease then was if you had a heart attack, stay in bed for 6 weeks.
Oh, brilliant.
Yeah, that's what it was. And they didn't really have, you know, Medicaid. They had like nitroglycerin, and that was about it. And I think beta blockers were right about then, but that was about it. And they gave you, you know, the diabetic diet, which was about 70% carbohydrates even then. And they weren't allowed to get out of bed. And one of the biochemistry teachers at the medical school where I went to in Iowa he was 43, he had a heart attack, and we were visiting him. You know, he was a great guy. Everybody liked him, and they wouldn't let him get out of bed, and we're watching him get worse and worse and worse.
Wow.
And I said, you gotta get out, you gotta move. You can't sit in bed and creak. And no, you know, he was dead within 2 years.
Oh.
And then I saw, I think it was a news show or something about this guy Pritikin, who wasn't a doctor, by the way. So, you know, so he was, you know, not to be believed, that he had done research, and he had had a heart attack when he was young. And he said, I'm not staying in bed. He was an engineer, and he did some research, and, you know, some of the research was a little bit faulty, but he found out that, you know, high fat diets, you know, saturated fat diets were an issue. Okay. We've learned a lot since then.
We sure have.
Not so much that, but they rented, I think they rented or they bought a hotel on the beach in Santa Monica, and they put these guys. It was all guys. There weren't any women then. 10% fat diet, low fat, 10% fat diet, and they made them walk every day, which was like unheard of. And some of them couldn't go 100 feet. You know, somebody had to go get them. But if they were, by the end of the month, the guys who had gotten there, you know, when I first got there, I mean, they were going 2, 3, 4 miles at a time without stopping, and their chest pain went away, and it was pretty remarkable. And I think the next year he was on 60 Minutes was a TV show, and he you know, and then the low fat diets became a thing, and then it turned out to be turned out to be a whole mishmash. That became the only thing, and you know, forgetting that the rest of the body needs cholesterol for things like your brain. 60% of your brain is made from cholesterol, and you know, when you limit it, you're sort of limiting things, and
your brain volume.
Brain volume, and then these drugs came out, and the drugs, you know, they work, you know, they lower your cholesterol, but you know, there's a price to be paid for them. So
and that's where it started.
That was way back in the 70s. In the late 80s, so now I'm in practice, and in the late 80s, we did it was basically a protein sparing modified diet. It was basically intermittent fasting. Okay, we used some protein shakes with it. That was like in the late 80s. So we did that. And I don't know if you're allowed to, there was a commercial product in the US that had a catchy title: a shake for breakfast, a shake for lunch, and a sensible dinner. That was their tagline. That's basically what we. And the people, you know, they did lose weight, and we were actually at cardiac rehab So rehabilitation now, exercise for heart patients became a thing in the 80s. And I actually got a certificate as a certified cardiac rehab specialist
Wow.
at the University
Yeah.
of Wisconsin La Crosse, and I think it was 1986. And so that became, so we tied that at the hospital with this, our protein sparing modified test, and we did that. Then I went to acupuncture school at UCLA, and I'm in Northeast Pennsylvania, which is coal country, and it was a little difficult because they weren't, they're meat and potatoes, folks. They were coal. That's where coal was discovered to be able to be used for heat, and that's a whole story in itself. But so those, and the mines there closed in 1959 because one of the coal companies dug too close to the river, and the river broke through and it flooded all the mines within 2 weeks. So when I got there in 1980, they were still waiting for the mines to reopen, and I don't think they have yet. So
Yeah.
but so I actually started one of the first acupuncture clinics in a rehab hospital. So it was it was a John Hines Rehabilitation Center. So if you had surgery, you had hip surgery, knee surgery, that's where you went after the hospital. And then we did acupuncture on these folks, and we got them out of there with 3 to 5 days sooner than those that didn't. So I mean, we really proved ourselves. Okay.
Yep.
And that was 1994. So, I had dark hair then and no wrinkles.
Yeah, this is I can remember that, the 1994. I can remember the 80s. I can remember the Pritikin. So yeah, I'm pretty old too.
Yeah.
But
I was on my own until 95, and then I actually joined up with a big group because, running a medical business and whatnot was
it's
huge.
not,
And so I was in a big group, and they were insurance based, and that was it. And I didn't really like that all that much, but I kind of put up with it. And then I went to, it was a bad winter. It was 2003, and I went to Disney World just to get out of the cold. Northeast Pennsylvania is picture. I don't know what New Zealand's like, but I don't know if you know what the weather's like in Chicago in the winter.
Gold.
So take Chicago and put it at 3 to 4,000 feet. So
Yeah,
it's
freezing.
Terrible cold and higher up. So a lot of snow and a lot of ice. So by March, I'm out of my mind if I can't get out of there. So I got a card that was the internet was just getting started then. Skills workshop. So I didn't even care what it was. It was at Disney World. So I go to Disney World, and I looked up that it was there was an Aerosmith exhibit there. So that was the big attraction. Okay.
Yeah.
And I did go to the skills workshop, and I learned 2 skills. One was testosterone pellet implants, which, who used that?
Yeah.
We were just told testosterone causes prostate cancer. Don't ever use it. We were taught on that.
Gosh,
and then there was
so wrong.
and then there was this new stuff that had come out that I actually had known about, that had come out for, you shoot it in people's faces and it gets rid of wrinkles. And
Lasers?
It only been out about 6 months. Yeah, it was Botox.
Botox. Okay.
But nobody, we didn't know what it was. I did know what it was because I had an aunt who she had it was made for, it was one of those things that was made for blepharospasm, eye twitch. That's what it was made for. She had that her whole life, and our kids, we can be mean. We used to call her Twitch. That was her that was her nickname. And she went and had it done, and she only had it on one eye. And she came back, and I went to visit her in a couple, like a week later, and the right side of her face was all smoothed out. She was 85 years old.
Wow.
And the twitch was gone. I mean, it was amazing. I said, where did all your wrinkles go? And she goes, what are you talking about? I says, well, this side of your face is smooth, the forehead, and this side's not. Right. And she goes, I don't know. They shot the stuff in me and then stopped the twitch. And, it lasts 3 months and it started again. So I kind of knew what it was because that's what it was made for. That was like 1991. Actually, it would have been out, but it didn't start using it for cosmetic until 2003. And I went home, and I had a good friend who was a plastic surgeon. And I said, you know anything about this stuff? And he didn't. He didn't know what it was. So I was the first one in Wilkes-Barre, PA to do
To
that I
notice that
know
it
of,
stopped
to,
wrinkles.
to do Botox, and we used big needles, and we
Wow.
got a lot of bleeding and a lot of bruising. And we also got we were able to charge twice as much as we do now, and it costs twice as much. But
To
that's
do,
another
yeah.
story.
Yeah.
So that kind of started me on that path, and then one day I went to visit my parents. I used to so my parents lived in Philadelphia. It was about 150 miles away, and we used to on the weekends every once in a while meet about halfway. And there was a hotel with a dinner. It was a dinner theater, and I got there early. It was on a weekend, and I was just kind of wandering around. And there's these people with a laser machine, and so I wandered in. I told him I was a doctor, and and it was a kid. He was 25 years old. I said, "You don't need to be a plastic surgeon to do this." He was like a year out of college, and he was hired by the laser company, and he was doing hair removal. I said, "Well, this is pretty neat." And so we started doing laser hair removal, and then that got that sort of like ironing, That's not one of my favorites. Um, and then fillers came out, so we started doing that, and I'd already always done a little bit. So with with acupuncture, so I actually learned about Chinese herbs and herbal remedies and whatnot. And I used to use the raw herbs, and get them, and have the patients cook them, and you have to put them in different times, and that they would come, and there would be twigs and rocks and in a bag, and sometimes there were bugs in there, and I might have some liability with this. So by that time, so I stopped doing that for a while. But by that time, there were American companies were compressing the Chinese herbs into pills. That I'm sure it's not the same, but
Yep.
so we started using those, and then one day I went to now remember I'm in Northeast Pennsylvania, wintertime, right? So I think it was 2007, somewhere around there. Again, have to get out of the winter. I went to Las Vegas and to a family practice conference, which was just about the worst thing. I mean, it was just dreadful. And those conferences were, you need the credit, you need the education. So you signed in, and then go play, basically. So I went and I sat, and I remember there was a lecture on, we were still handwriting prescriptions, tall letters. They were so that they could read it. So my handwriting isn't too terrific to begin. I have doctor's handwriting to begin with, since I got a D in handwriting in 6th grade. So I was sort of do this. So I just I wandered and across the hall. There was another group, so I wandered in, and the guy who's teaching, I told him who I was. I was a priest. He says, "Well, come sit down and listen." And his name was Neil Rosier. I don't know if you ever who he is, and he's one of the sort of the original gurus of bioidentical hormone.
Oh,
And
wow.
that's what
Yeah.
he was. And I wandered in.
You listened to a lecture on that.
I didn't know who they were. I didn't know what they were doing. And I'm sitting here and listening to this, and I'm saying, this makes sense.
Yeah. Yeah,
So
it does.
all these,
I mean, that's a good place to jump off, maybe, into the actual stuff. I mean, that's a bit of a whirlwind tour through 40 odd years of anti-aging medicine.
that was only about 20. That was maybe 25. So
25 years of anti-aging medicine. But what that illustrates, though, is how much medicine got wrong at the beginning, and parts of it were right, and then it's changed and it's evolved. And there's no difference now, is there?
yeah. So, well, in some quarters, yes. So if you've noticed my last, I sort of developed a theme now in the talks I give, in the lectures and the PowerPoints, and I always have, it's in parentheses, nearly everything we learned about fill in the blank. I have hormone optimization, testosterone, estrogen, progesterone, thyroid was wrong in medical school was wrong. So it's nearly everything we learned about thyroid disease in medical school was wrong. Nearly everything we learned about hormone optimization was wrong. Nearly everything we learned about almost everything was wrong, as it turns out. And I'm sure 30 years from now, they're going to look back at what we're doing and saying that was wrong. So
exactly.
That's how things, sort of
how it
develop.
grows. Yeah. And how we develop.
We're doing things way differently now than when we started. Remember when I was Dr. Rosier's classes way back when, the goals that we're looking for, and different, different, treatment goals and whatnot are way different than they were. They're a lot lower for the most part, for most of them. We didn't really have anything to go on. Basically, all we had was the I call them the gym rats,
Yeah,
the body
bodybuilders.
bodybuilders, the 18 to 22-year-old kids doing stacks, steroids and whatnot. We really didn't have anything else to go on. And so, for
What?
instance, for for uh, for men, like a 50-year-old man who's got very low testosterone, our treatment, we try to get his total testosterone to 1,500, and then testosterone aromatizes or breaks down into estrogen,
Estrogen.
and
Yep.
then get the man boobs and whatnot, and so then we would give him estrogen blockers to get it to 0.
Which is not
Well,
good. Not good.
that turned out to be wrong either, but we quickly learned how to do things, and then we once we got kind of the basics down, then so late, the last 10 years or so, we've branched out into many areas. So we see a lot of traumatic brain injuries, we see a lot of head injuries.
Yep.
And if you think about it, it makes sense, because where the hormones generated right in the center of the brain is the hypothalamus and the pituitary gland, and you shake that brain up, what's going to happen? Those the hormone generators are going to get disrupted.
Actually,
And
let's talk about this a little bit, because yeah, we need to get into the meat and potatoes of the stuff that we want to cover off today. And hormones is one of those major places that I wanted to hit. And I've done a lot of work in the brain rehabilitation space, and I love Dr. Mark Gordon's work, who I think you know about as well.
he was one of my mentors, and I fight with him too
Wow.
now, because I
Yep.
sometimes
You don't agree with everything, but
yeah.
he sort of like brought to awareness among you and others as well, but that hormones have been often, when you've had a brain injury, that pituitary gland and that hypothalamus has gone offline, for the want of a better description, being damaged, isn't producing the hormone. So it's something that we need to check. So how do you, like, if someone presents with a brain injury, what are the sort of things that you do as a workup for them?
Well, again, we try to take a pretty good history and find out what happened, and what's happened to them from the time of the brain injury to the time they show up. I always say that, it's not a coincidence. When they show up, in front of me, there's a reason for it.
Yeah.
It's time to do something different. We see a lot of veterans, after 9 years of wrestling with the VA here in Reno, we're slowly making some progress.
Great.
And because they would put these guys on 5 different antidepressants and
Yeah.
three psychotics, and then 4
Yep.
other drugs, so to counteract the side
All the
effects
other.
from the first 5, right?
It's
And
disaster.
the guy wandered in here. I have what I call shrink wrap on my windows, and I'm next to actually a big like service, the gas station and candy, like I don't know if they'd have 7-Elevens there
Yeah.
where you
Yep.
are.
We do.
No,
Yep.
right? So we're right next to it, and so this guy wandered in. He had no hair. I mean, literally no hair, nowhere. And he had no head hair. He had no chin. I mean, he had no hair on his arms. And he said he doesn't had done any. And he'd been in a rollover crash in Iraq, and he was on 13 medications a day,
Oh.
34 doses, and he was
Oh.
basically living under a bridge. And he one day he was in a store. He said he had some money. He doesn't know what came over him. He stole something. He stole nothing.
Yep.
$5 something, and he got caught, and he ended up going to jail
Oh.
for it. And he wandered in here, and he looked, but things were slow, and I don't know. We kind of took to each other, so I started asking him. I said, do you get hot flashes? Yeah. Do you get night sweats? Yes. And dry skin, dry hair. Your fingernails. He showed me his fingernails. They were all, basically didn't have any. Any no libido, no, very depressed, no muscle tone, and he had a urinary dribbling, and his blood sugar was, like 140, sort of
Wow.
borderline dietetic,
Oh,
and so I'm going through my paces here. I call it a hormone centric view.
yeah.
So I do this with every person that I see, every patient that I see, is I ask them, the hormone excess and deficiency questions. That's how
Mhm.
I kind of look at it. And he checked them all off, and they said, "Oh no, I have severe depression. I have schizoid, whatever." And I said, "That sounds like a testosterone deficiency to me." Right? He says, "Yeah, he had no, his memory was shot. He couldn't concentrate on anything. He couldn't start. If you gave him something to do, he could, it would take him three months to even get started. Um, uh, then he never finished anything, and he couldn't do two things at once. And he was very obsessive compulsive. They told him he had obsessive compulsive disease. He couldn't leave home, couldn't leave where he was living without making sure his shoes were all lined up, and his
Yeah,
shirts
yeah.
had to be color order, that kind of thing. And he was paranoid and all. I said, that's growth hormone deficiency, right?
Wow.
So I said to him, I said, he was a veteran, so I gave him a lab slip, and I said, let's see what we got. And he came back a few days later. He says, they laughed at me. They won't do this.
What?
So yeah, they wouldn't do it. So I actually have a deal with a lab. We have a pretty good deal with a lab. So I paid for it myself, and I sent him down there
Wow.
uh, to our right. And he had no thyroid function. He had no testosterone. He had no estrogen. He had no growth hormone. I mean, barely. Barely a blip. I mean, he had basically nothing.
Wow.
So I made my first mistake. I wanted to fix it all, yesterday. Well, turns out with hormones, especially if you've been depleted of them for a long time, that's not a good thing to do.
You
So
gotta slow.
he
Yep.
had a psychotic reaction, and thank God he sort of stuck in there, stuck it with me. So we had to start over from the beginning, and then we started doing it, slowly and gradually, and we took one hormone at a time and sort of optimized that. And it took us like 2 years to
Mhm.
get him up to speed, doing it that way. But turns out he's got a beard down to here now, by the way. He's a little bit, but
Oh,
he's
I've seen
checked
him
his
on
birthday.
your
Yeah,
webinars.
Joel, yeah, that's him, right? You've heard
Oh.
you right? In fact, it's his birthday tomorrow. Thanks for reminding me. Um,
He's a
and
character.
oh, he's a character, all right. Turns out he's extremely bright. He sort of woke up. He reconnected with his family. He had been estranged from his family for 20 years. He ended up he's a coordinator for the suicide hotline at the Veterans Administration here now. He's got his own 401 or 501(c)(3) for veterans. And he bought his own house. He bought his own car. Which is
Yes.
that wasn't even anything on the radar. He's took it. He reconnected with his father, who also has a beard down there.
Wow.
um,
What a
and
story.
yeah, so we turned him around, and then there's 1,000 other guys and gals like that
Mm-mm.
at the VA.
Yeah.
So again, they didn't want anything to do with it. They all had to go see the endocrinologist, who was about
Oh,
800
yeah.
years old,
Yeah.
hadn't opened the book since
No
1964.
comment. Yeah.
Yeah. So we didn't get very far, but I think he's gone now. There's a younger guy there, and so we're making a little bit of headway. They'll take our labs now. They will run them. They're still not quite up to. They'll give them a shot of testosterone if their testosterone is less than 300. They'll give them one shot a month. Now,
Wow.
considering it's half gone in 12 days, the shots, it's
That's
like
not the way
starting.
to dose it. Yeah. I mean,
Yeah, but it's
and
better than nothing.
I know. I mean, we face the same sort of problems here, and I have a lot of people coming into my clinic who've got brain injuries, and the first thing I do is a hormone workup. Like to try to work out what's going on. If that has been affected, it isn't always affected with brain injuries, but it is a lot of the time. And then a gut health, microbiome workup to see what's going on in the gut, because that's very often also with brain injuries, isn't it?
Yeah. So we start with the hormones, and then we do the gut health, and Lately we've been seeing, you know, the more I learn, the more I'm seeing. So lately, my latest, one of my latest crusades is we've been looking for mold. Now, Reno's a high desert. You wouldn't think there would be much mold here, but the last 32 patients that I've actually tested for mold, 30 of them have been positive.
Wow.
So, and there isn't any, I don't know, there isn't any, yeah, you're complaining of this and that means you have mold. I mean, it's just very, there's a lot of symptoms and
Yeah,
none of
sort
them are
of.
very good for anything.
Yep.
So, so you got to kind of, piece it together.
Yep. And
So
there is an online questionnaire that they do. I've forgotten the name of it now.
yeah, visual VCS,
Yeah,
it's called.
VCS. Yeah, yeah. Do you think that
Yeah.
has any validity at all?
It's an okay screen. If it's positive, we're probably looking at mold. If it's negative, that doesn't mean it's not.
Right.
Okay. It's an okay screen, and there's two warring factions in the US on mold. There's a Dr. Shoemaker on one side, he's the one who developed the VCS, and then there's Dr. Andrew Campbell, who's on the other side, and they sort of lock heads. So Dr. Shoemaker looks at it as like a chronic inflammatory response, and he does binders, and he'll do the urine test. Dr. Campbell says there's no validity to the urine test, and there's no literature on the binders, so they sort of lock heads.
Crash heads, yeah.
I've had more success with Dr. Campbell's approach. But if the patients aren't, completely better within 6 months, 6 to 8 months, then I'll add in the other one, and that seems to work out pretty well.
Wow.
So
okay.
I do it hybrid. So both of them are mad at me.
Oh, you're going to make people mad, and I mean, it's great that we have people that are trying to work all these things out, and they're not all going to agree. I mean, I interview doctors and scientists every week on my show, and they don't all agree with each other. And but I welcome all opinions, because then we learn, right? When we have robust debates about things, and we can openly talk about, where, because what I do find is a lot of scientists, especially who are like PhDs and things, that are right down one rabbit hole, sometimes lose the perspective of the whole person, and don't see or I find that ones who aren't in clinical practice are often, theoretically this all works on paper, but is it actually working on the patient, and there's quite a disconnect sometimes as well. Yeah. So they can be right when it comes to Petri dishes and stuff.
That takes us back to the cardiologist and cholesterol again.
Yeah.
They want the cholesterol to be zero,
which is a disaster, right?
No matter what. It doesn't matter what. I said, well, what's that going to do to the rest of their body? He said, well, we don't care. Their heart will be good.
Their heart's okay.
Well,
Now, I mean, and then you got, people like Peter Attia and things that are going, LDL's got to be as low as possible. And there's a reason for it to be there. And it's all homeostasis. It's all getting it in the right balance. And cholesterol is, when I see a really low cholesterol, I mean, the studies are out now that we know that, actually you want a lot of the good cholesterol. You want to watch the oxidized LDLs. You want to do the, LP little A and PLA, and, to work out the density of all of these cholesterol molecules. Right. It's not just the HDL and the LDL, the particle size. That's it. Yeah.
Fluffiness and particles. And
the fluffiness and all of that. And then also the inflammatory state of the person. If they're inflamed and they've got a lot of macrophages, and doing their thing and causing, and you've got, a lack of nutrients and things like vitamin C, which really help protect, all of these things are aspects of it, aren't they? That is missed in these big headlines. Cholesterol is bad, and we, like I've got quite a high cholesterol level, but I've got a really good HDL, and my the breakdown of my cholesterol is beautiful. So I'm not worried about the fact that it's high, that the total cholesterol is high, not at all, because I'm taking the fish oils and the olive oils and the things that is actually keeping it,
Some of it's genetic. So I told you about my father. He did everything the opposite. His blood sugar was a 240 from 1987 on. His cholesterol was 500. he never, his idea of exercise was hitting the clicker on the television, right?
And he lived
He
to
was
what,
not
95?
Well, he was 95 when the COVID shutdown came, and he laid down. He said, the casinos will never open again. I have nothing to do. So that's it. I'm done. And he pulled a sheet over his head, and that was it. He was done. Right.
Really?
He'd still, yeah, he'd still be, he'd have been 99 this year. He'd still be, I swear to God, I know he would still be here. He'd still be going by himself to the casino. I know, to casinos. I know he would have. Right. He was just too stubborn. He wouldn't take insulin because he said it was made from pigs. He says, I don't do pigs. I said, what did you have for breakfast, Dad? Bacon and eggs. Right?
Oh, what a character. But yeah, there's
Yeah,
genetics.
every doctor wanted to give him insulin, and he told him to go, he told him, get out, go away.
Get out of here.
Yeah.
Oh, that's funny. And genetics play a huge role for sure. Like there's some people who should have, the butters and the good fats, and there are people who shouldn't, and that's all of this nuance of this conversation. We need to personalize medicine. We need to find out what your genetics are. We need to see what your environment, what your history.
Genetic testing you can do now. You can do
Yeah,
genetic testing, someone, to match their
I do it. Yeah,
medications and herbs.
Yeah. Yeah, and it's going to be, as things unravel in the next few years, we'll be able to even go, right down into the nitty gritty of whether this medication is right for you. We're not quite there yet for the general public. But just coming back to the hormones, I am a big fan. I'm personally on bioidentical hormone replacement. Can you comment on the Women's Health Initiative did a massive disservice to women. Disastrous, and I still get that.
I won't use the 4-letter words. As soon as you mention that come to mind.
Yeah, exactly.
So let's go back in history again a little bit before that. I don't know if you know this or not, but I was an OBGYN. I was a failed OBGYN resident. 1979 to 1981 for 2 years. I didn't, that was enough for me. But we would do hysterectomies because that's what, gynecologists
That's what we did. Yeah.
We would give our patients Premarin, which was the synthetic estrogen.
Yeah.
Right. And we told them they didn't need progesterone because they didn't have a uterus, so they didn't need that anymore. Actually do a whole lecture now on progesterone after hysterectomy, and with I have 32 documented evidence-based reasons to use progesterone after hysterectomy, and the one reason not to is because they can't get pregnant, right? So, well, they can't.
They can't. Right? No,
you take the uterus out, you're not going to get pregnant. So and we would, and then I remember saying so we would have a post-op clinic, or and for the babies, Tuesdays and Thursdays from 2 to 4 in the afternoon. And I remember saying to one of the senior residents, I said, these women come back. We did a hysterectomy 2 years ago, and they come back, and half of them have breast cancer. And they said, yeah, well, that's just kind of the way life is. And so in 1980, we knew, at least I knew, that was an issue, right? I didn't really put 2 and 2 together. So this WHI study comes out, and I remember Premarin was the most prescribed drug from, I think, 1970 right up into 2002 in the history of the world. In the history of the world. And if your viewers don't know, Premarin is synthetic estrogen. It was made from the urine of mares.
Yeah, of horses.
So
yep.
It has 3 human. It's 10 different types of estrogen molecules, only 3 of which were human. The other 7 were not. And the estrogen for females is affects the female or sex organs. So it's the breast, the uterus, and the ovaries for the most part. I mean, it does other lots of other things too, but it should take all of 20 seconds to figure out why you would give somebody a highly inflammatory foreign substance that will affect your sex organs. And they're going to form. So what's cancer? Cancer is, abnormal cells, abnormal growth of cells is what it is. So how does the body protect itself from a foreign invader? It builds walls, it builds cells around the organs that are affected. Okay, can you put 2 and 2 together now? I mean, how long?
It causes cancer.
How long did that take? Yeah, I mean, that should have been obvious.
Yeah, and that scared women off bioidentical hormone replacement, because that wasn't even a word back then, because it was just hormone replacement. And now people are still scared.
So Prometrium, which is natural progesterone, had come out in 1998. And so progesterone is the balance for estrogen. So the powers that be, and I have this in my earlier lectures, I've kind of, we're kind of beyond that now, said it didn't matter what type of hormone it was, if it was natural, which is chemically the same as we make, or the synthetic, it didn't matter. It was all bad. Well, it turned out that it didn't matter, and it wasn't all bad. The natural estrogens actually, estrogens and progesterones actually have less incidence of cancers than if we gave you nothing at all. So there was a French study came out 5 years later, 2007. It's the E3N, I think it's called, and it showed had as a baseline. And remember, and the numbers. So the numbers are a little bit deceiving. Also, it's there's statistics, and then you can make them say whichever you want. So if we don't give you any hormones, if they gave you no hormones at all, about 10 women out of 100,000 would develop a breast cancer. If we gave you Premarin, the synthetic progesterone, on average, it was about 20% higher. Okay. Well, what's 20% of 10?
Well, yeah, two more people. Yeah.
two out of 100,000. Now, if you're one of the two, it's unfortunate.
But that's the synthetic. Yeah.
But if you look at it and you're saying, well, wait a minute, that's not that terrible, right? It is 20% more, but it's kind of misleading. If we gave you Premarin and Provera, so the estrogen progesterone combination, it was 40% more than if you had no hormones at all. But if we gave you the natural estrogen and the natural progesterone, it was actually 10% less than if we gave you nothing at all. Wow. 50% if we gave you the synthetic combination, and 30% less than if we gave you just the synthetic estrogen. Wow. So the natural estrogens, natural progesterone actually will actually protect against breast cancer.
Yeah.
And again, so it's 10% less, which is how many? One.
Yeah. And this is and this also doesn't take into account anything about that person's environment, their lifestyle, all of these factors, which also should be taken into consideration when you're looking at HRT, or how you process out. I love doing the Dutch test, the hormone dried urine test of complete hormones, and looking at the proportion that's going down the 2-OH versus the 4-OH versus the 16-OH, and how's your methylation, and how's your, organic acids stacking up, and how's your cortisol, all of these parts of that equation, right? That should be considered, not just, whack it in or don't whack it in. And didn't the Premarin make more estrone, which is the more deleterious?
That's the bad guy,
Yeah, and this is why women... and naturally we make more estrone in our later 40s and 50s, don't we? Just naturally anyway. Yeah, so you have to push it down try and push it back over to the estradiol form and down the right path.
And they came up with, maybe the natural estrogens are okay, but only for the first 10 years after menopause. Well, what are the 3 big killers of women? Heart disease.
Yep.
Breast cancer and cognitive, decline,
Alzheimer's, which needs estrogen.
and what does estrogen protect against?
Heart disease and also, cancer, and
and also osteoporosis.
And that's a major one. That's a major one. Like osteoporosis. Like my mum is 82, and I have her on testosterone, estrogen, progesterone.
So your mom's 82. We're not supposed to give her any of that stuff.
I know, but I have enlightened doctors that I work with.
I said, well, then what? Well, according to, and I haven't looked at it lately, but the American College of Clinical Endocrinology, their first line recommendation is Effexor, venlafaxine, which is SSRI, SNRI.
Oh, yeah, no.
Which is probably one of the worst drugs. Any of my students prescribe that, they fail.
Yeah,
it's highly addictive, and you get called on Saturday night. I left my effects are at home. I'm in Hawaii and I've been here 24 hours and I'm jumping out of my skin. Can you
Yep.
call, to get some? So
It's
please stay away.
dangerous. It's dangerous. I've got a client that I'm working with at the moment who's trying to titrate down, under the guidance of doctors as well. But we're working, and he's got a brain injury. For years, I've told him he's just depressed. He's just depressed. Well, we've done a full workup with him, and I've got a couple of colleagues that work on neurofeedback and all of that sort of stuff, and neurochiro, and he is miles better already. He's been doing hyperbaric oxygen therapy, but the hard thing is we're having to titrate him down off this terrible drug that's going to take us a long time to get right down off it. And that's something like methylene blue, like that brings that point up. Like methylene blue could help with a lot of these things too.
We really lucked out with methylene blue. So
didn't we?
It was invented as a dye, a blue dye, in Europe, in Germany and Austria in the 1870s. And the dye maker, the clothing makers noted, those places weren't exactly clean, right? And they noticed that there a lot of the bacteria, about the bug, all the things that were kind of around there. You don't see that stuff in Western movies, or you don't hear about that kind of stuff, but it was pretty prevalent. And the methylene blue killed the bacteria that if they spill it on the floor wiped it, they wiped it up, and the floor was a little bit blue, but all of the schmutz that was on the floor was gone.
Yep.
So about 10 years later, in the late 1880s, scientists took the stuff and they sort of distilled it down, and they made it into kind of a food grade so that it wouldn't kill you.
No contaminants.
They used it as an antibiotic, and they used it as an antiviral, and it has antifungal properties. And they used it up until about the 1920s. And then in the US in 1912, there was something called the Flexner Report. And if it wasn't strict medicine or surgery, it was thrown out. And methylene blue, got homeopathic remedies were thrown out, chiropractic was out, herbs were thrown, all of it was no good. And so methylene blue got put into that category. Now, fast forward 100 years, and now we have, these, crazy viruses, and, think about wherever the hell they came from. Well, bugs like to live. That's why they kept having these variants, right? We something and get rid of the COVID-1, and then now all of a sudden you got COVID-2, and whether you think it's a conspiracy and half of it was a bunch of hooey is another story. But methylene blue was an antiviral that hadn't been used for 100 years, and so the bugs weren't used to it, and it was actually quite effective. So of course,
they stopped that. Because they used it in small clinical trials in people in ICU, didn't they? And they had a huge success with methylene blue, and then it got shut down, like everything else.
And we use it in long COVID also now. So these people that it's they have these like lingering symptoms, and they've had neurological damage and and immune damage. That's semi or even permanent. And we've had some very good success with that, along with other things. It's not just one thing.
No,
but the methylene blue was quite a it's sort of a kind of a breakthrough. Sort of gave us something that we could really depend on. The issue was getting it, and then you had to warn the patient that it'll turn their urine blue. So,
I've got blue urine.
It was a little bit of frightening, and again, the VA didn't like that.
It's crazy, like methylene blue, and I highly recommend that everyone go and watch Dr. Clearfield's lecture on methylene blue. It is the best lecture on the internet for methylene blue, and see what it's good for. Like this stuff is amazing.
It's about 20 things.
It makes more energy, helps with mitochondrial dysfunction, helps with hemoglobinemia. It helps with UTIs, which is one of the major reasons that I've used it with my mum. And she's got a blue bum now, but that's okay. Like she's hasn't had a UTI since we started using it.
Don't spill it on a white couch, by the way.
No, she gets strict instructions not to tip it over because it will dye everything.
You have a white carpet also. That's probably you're
Yeah.
gonna be dying at blue.
I
So
would love to see methylene blue like accepted in the mainstream. I mean, they use it in the hospitals for things like sepsis in some countries. They use it,
they use
for the inducible nitric
hemoglobin.
oxide problems. Yeah, yeah, for carbon
Yeah,
dioxide poisoning, for cyanide poisoning, things like that. Emergency, but they don't use it for all the other things that it could be great for. And it's just like, wow, this is easy, cheap, something that could be done. But
yeah.
anything that's easy and cheap seems to get the kibosh. And it was originally an anti-malaria drug too, and it's making a comeback for that, isn't it, as well, because they're becoming
Right,
resistant to the antibiotics.
so, that's okay. We don't want to give out all our secrets. That's why they can't they can't figure. The endocrinologist here in town, if you call them in the morning, they'll say, "Are you can you be here by 3 o'clock in the afternoon?" If you call me, I say, "Can you be here in November?" So they can't figure that out.
I love it. So that's methylene blue. Go and check it out, everyone. That lecture is really that really dives into the weeds on methylene blue and is a very, very powerful lecture. One of the other great things that I've, that I love is another drug called low dose naltrexone, which also has a very interesting backstory that it was used for opioid use at high doses, so like to try to get people off opiates. And then I've forgotten the name of the doctor, but he started to titrate it down as he was getting his AIDS patients.
But I think his name was Batari.
Yes, that's the one. And he was titrating it down, getting his patients off the opioids. And then he noticed that they started to have all these benefits at the very low levels, at 3 milligrams and 4.5 milligrams and that sort of level, that they started to have all these anti-inflammatory benefits. The cytokines were, down regulated. The immune system was better. Can you tell us a little bit about low dose naltrexone and why I'm
Right. So naltrexone is a medication. It's been around since the 60s. I think it was FDA approved in 1984 at 50 and 100 milligrams for it's an opioid blocker. So you can take, if you take naltrexone, it's got about a 36-hour half-life, so it'll last about a day and a half, one pill. If you take it every day, you can do drugs all day. You can drink all you want, and you won't get high.
You won't get high.
You won't get high.
It's a good way to get off
it. Yeah. So why this Dr. Batari in New York City decided to do this, I don't know. So in the mid 80s is when the AIDS crisis came about, and I was actually in Wilkes-Barre. Believe it or not, we had a fairly high population of AIDS patients, and there was only one doctor in town that would see these folks, and you're talking to him.
Wow.
So
amazing.
Because everybody, they were all afraid, and everybody was going to die from it. You know what it was.
Like the COVID
stuff. All these crazy infections, and one day, the guy's perfectly fine, and 6 hours later, he's in the ER, with delirium, and he had a cytomegalovirus meningitis, and I mean, we never saw stuff like this, and pneumocystis carinii, which are these sort of bacteria. I don't remember if it's a bacteria parasite, in the lungs, and where the hell was this stuff coming from? And so they had their immune system was shot.
It's gone.
And their endorphin levels were about a third of what they should have been.
Wow.
So however it came about, when he watered down the naltrexone from 50 milligrams to 5, so he took a 10% of the full dose. It has very different properties. It has one set of properties is that it will work for about 6 hours or 8 hours at a 4.5 milligram dose, and then it wears off. While it's effective, it blocks the opioid receptors.
Yeah.
Briefly, our body's reaction to it is to make endorphins. When the medication wears off, the opioid receptors are open. The endorphins rush in and fill the opioid receptors. So endorphins, or beta endorphin, is the most potent anti-inflammatory that we make naturally. Wow. I'm sure you're an athlete and all. I'm sure you've had like the runner's high, that kind of thing.
Yeah. It's totally.
The same effect. You don't get the high, but it's the same effect. It's that kind of but it's that same effect. And so that's how it works, basically. And also
great antidepressive then. So that would this help with antidepressive?
Yeah, I mean, there's indications as long as both of your arms and both of your legs.
Yeah.
There's whole societies, dedicated to this now, and there's very specific dosing instructions. We use it a lot for autoimmune thyroid disease. I mean, it's very, very potent for that. But you have to use it in lower doses than even the highest dose of low dose naltrexone. The thyroid is very sensitive to this, and patients, especially if they're on thyroid medication, will frequently become overdosed. And so we have to
Right.
watch their thyroid levels, and we frequently reduce their medication. Sometimes we can get them off of it also.
Wow.
Uh,
Yeah.
the other ones that are extremely sensitive to it are MS patients, multiple sclerosis. And so usually the highest dose we'll use now for low dose naltrexone for most general things is 4.5 milligrams, but for the thyroid and for multiple sclerosis, never more than 3.
Never more than
Okay, so
3. Yep.
and we start low and we kind of build it over a couple of weeks. So
Yep.
you don't want to start out. There's a few side effects that are pretty minor. It's pretty clean. One of them is so we usually dose it at bedtime with the idea that it lasts about 6 to 8 hours. The opioid receptors are blocked and then it wears off. So that by the time you wake up in the morning, now you're good to go. Right?
Yeah. Yeah.
About 10% of the patients end up with some sort of insomnia where it keeps them awake. The good news is it happens in the first day or two. So we usually tell the patients, if you're off on the weekend, take it on a Friday or Saturday night if you're not working the next day. If it keeps you up, then there's a whole treatment dose schedule, 2 hours earlier, 2 hours earlier. That's okay. After a while, I kind of got tired of this. I just told them, if it keeps you awake, just take it in the morning.
Take it in the morning. Yeah. Yeah.
Yeah.
And
it doesn't make them sleepy.
And vivid dreams is the other one that I get from it because I'm on it. And
that was third. That's about 20% of the patients.
Yeah.
And some of them tell me they're riding dragons and all sorts of crazy things.
Yeah, I was hanging out with The Rock last night, doing crazy stuff. So, it's cool. It's cool.
It can cause a little bit of nausea that usually is gone in a few days to a week. And we can usually cover that. I can think of 3 or 4 I've been using this stuff for about 25 years. I can think about 3 or 4 patients that I can think of off the top of my head that stopped, couldn't take it because it made them, it made them too sick to their stomach.
But it's so powerful. And things for anti-cancer, like cancer prevention, as a longevity molecule, for immune system regulation, for down regulation of a lot of the inflammatory cytokines. I don't have off the top of my head which ones, but I think interleukin 6 and tumor necrosis
interleukins
factor.
1 to 17 and then 18, 19, and 23 off it's just about
all of them. Wow. So
I don't have it off the top of my. I have a really nice slide in my presentation there, and it has them all. So
wow. Yeah, and that's another lecture that you guys must go and listen to if you want to really do a deep dive into low dose naltrexone, and if you're dealing with anything from multiple sclerosis to cancer prevention or cancer itself, it's used as an adjunct.
Pretty much any inflammatory issue at all, even from neck pain, back pain, to Hashimoto's thyroiditis, to lupus, to Sjogren's disease, to Crohn's disease. Any type of autoimmune issue. It's really pretty. If you're on opioids, you're really not supposed to use it, but we can use micro doses to try and wean you off of them. That's pretty much really the only reason not to use it if you're on, Oxycontins and
which are bad anyway, and try and get off those if you can.
So
and what about for long COVID? Would that be a good thing, with this sort of upregulated?
That's part of our protocol, along with methylene blue, and then we use some other anti-inflammatories. We like quercetin and nettle as combination, and then we use ivermectin.
Ivermectin. I mean, let's talk about ivermectin because it was ridiculed, and it's still, you go to ChatGPT. I did it today just for fun to have a look at what it says about ivermectin now, and it's still going, it's not standard of care, it's not this, it's not that. And it's like ivermectin has saved so many lives, and it's a horse.
So ivermectin is a very potent anti-inflammatory.
And
almost all of the cytokines that are covered with low dose naltrexone, ivermectin does that also. So
Yeah.
yes, it was developed as an anti-parasite drug, and but again, it does so much more. So
Yeah. And this is
real
like, yeah, sorry, to interrupt. This is what interests me, is like, one of my teachers, Dr. Elizabeth Yerth, and she's a fabulous cellular health expert and longevity orthopedic surgeon, and goodness knows what else she's done. She's done amazing. Anyway, she tells us that we need to learn the pathways, that we need to understand the pathways that are involved in different diseases, and then look at the drugs that are available. There's 32,000 drugs that are FDA approved, and start to work out what pathways are affected by these drugs, because there's a lot of off-label use that you can do, and they've already gone through their safety and all of these sort of things. Do you find that's a good approach as well?
We've done that. And again, we use the cytokines, which are the inflammatory proteins. We've tried to determine which inflammatory proteins are involved with name it. Okay.
Yeah.
And then we'll look at whatever substances we have that are have activity against
block
those.
that. Yeah.
Okay. And a lot of times you have to use, first of all, good quality stuff, especially in the over-the-counter markets.
Yeah, and the supplements.
You don't really know what you're getting. You have to use it. You have to use enough of it for a long enough period of time. So let's go back to ivermectin. So there was so much hullabaloo about it. So somebody, I don't remember who it was now, decided they were going to study it and write a paper. So our protocol was, I forget what the dose was looks like for somebody like you would be about 12 milligrams a day.
Yeah. Exactly what we've got. Yeah.
For 5 days. Right.
Perfect.
So they did a study on, I think it was on 600 women. They did 3 milligrams a day for 3 days, and then said it didn't work.
Oh, yeah, brilliant. And that was deliberately designed that way, no doubt.
Yeah. I mean, it'd be like saying, you have a strep throat. We're going to give you one. You need 4 penicillins a day, right? We're going to give you 1 a day, and if it doesn't work, well, then it's no good. I mean, and
this is the thing that really pisses me off with clinical research. They use science to manipulate it, because the general public doesn't know the nuance of that conversation that we just had there, right? We know that the dosing is 12 milligrams. The general public doesn't. All they see is the headline is ivermectin doesn't work. And that's wrong. And that's deliberately done by the big pharma companies, I believe, to hopefully I don't get banned for saying that, which should really, just proves the point if it does. But they do these things to manipulate, and they fight science with science. I mean, they did it with the tobacco industry in the 50s and 60s and 70s, where one side would be arguing the science that smoking's good for you. And the doctors used to say that, by the way. And then other side.
I have it framed in my office. It's an old magazine advertisement for camels.
Yeah.
It says 20,649 doctors say camels are good. It says it's toasted. It soothes your throat as it goes down.
Oh, exactly. And that should be a humbling reminder that we don't get everything right, and that there's lobby groups that are there to push the tobacco industry in that case, to refute the science of the ones who were saying it was bad. And now we know, but we can laugh at that and look back and go, oh, well, they were just dumb. No, we're doing the same things now,
We do the same thing. Yeah, I got dragged into the hydroxychloroquine thing.
Oh gosh.
Before the ivermectin. So yeah, one of my hats was I was the executive director of the American Osteopathic Society of Rheumatic Diseases. So rheumatic diseases used a lot of hydroxychloroquine for 45 years before, someone decided that, it might be, again, it's an anti-inflammatory, and it's got a lot of cytokine, anti-cytokine activity, that might be useful against COVID. And so the governor of Nevada one day just declared that he banned it from being prescribed for COVID.
Wow. Why? And ivermectin was banned here. Yeah.
Yeah. I mean, first of all, the guy I don't know, did you ever see Seinfeld? Do you remember Seinfeld?
Yeah. I'm that old.
Father? Remember his
Yep.
father, Morty?
Yep.
That was kind of that's who the governor of Nevada at the time reminded me of, right? What is Morty Seinfeld determining
Doing on
what,
there.
what, right?
And
So so us in the Nevada Osteopathic Medical Association, we ended up suing them, and they just let it run out after 4 months, and the only one who made out on that at all was the lawyers,
yeah.
but at least we got, they didn't keep renewing it, so. But
So
it was just
yeah, and
right?
it's all of this. Like, when do politicians start mixing in into the medical?
Well,
Not to mention the VX word, because that that's a complete disaster.
if you think about it, what other entity have you ever run across where they say, no, you can't do anything, you just go home until you're sick enough to then come back so you can die, right?
Yeah, no
My,
prevention, nothing.
I mean, well, my mother kept things to herself. She had some eye problems. She went to an eye doctor and he sent her for a chest X-ray for some reason. She never smoked in her life, but she spent a lot of time in casinos. She had stage 4 lung cancer in both lungs. So they sent her to an oncologist. He tells her she's got 4 weeks to live. So she calls me. I was living in Wilkes-Barre then. They were in Philadelphia, about 150 miles away at the time. So I wasn't right there. And she says, I feel fine. They're telling me I'm sick. I'm going to die in a month. She says, I told that doctor, he says, I'm going to live longer than you just to spite you. And she did, actually.
Yeah, and I've got similar stories. Mum was told so many times that she's got weeks to live and she's dying, or whatever.
Yeah.
And she's outlived some of those doctors as well.
So, at the time, I had just begun my anti-aging sort of studies at the time, and so I ran across his name was Mark Rosenberg. He was an integrative oncologist in Miami. So we consulted with him. He gave me a whole long list of things to do for her. We did about a third of them because she wasn't going to do all of it. And every once in a while, you get a call or a letter or a note from the oncologist. She's still here. I can't explain it. Right. A year later, 2 years later, 2.5 years later, she was supposed to be dead in 4 weeks. Then he got hit by a car. So she did outlive him. I don't know. So,
yeah, it's not nice, but yeah. And this is the thing. It's not always that doctor knows everything in the planet. And certainly now, like the medical knowledge, I heard a statistic recently, is doubling every 72 days. And so there's no person on the planet that's across everything, And on that point, I did want to dive briefly into, we probably need to do a complete another session on this one, but thyroid. Thyroid is an area that I've been learning a lot from you on. And, things like Hashimoto's and, how you do a thyroid workup has been a real eye-opener for me. And all this, the nuance of conversation, because you go to a normal doctor, they'll do a TSH and they go, yeah, no, you're fine. Your TSH is normal. What's wrong with that picture?
Well, again, someone came up with sort of a semi-artificial test and said, this is it, this is the gold standard, and don't do anything else.
Yeah.
Again, the endocrinologist, and they were unanimous about it. You put 10 doctors in a room and they're not unanimous about anything, but this they were unanimous about, right? They decided that this one test called a TSH, thyroid stimulating hormone, which is the pituitary secretion of thyroid for the thyroid molecule, that would be the gold standard, and that's it. And you don't do anything else. Well, that didn't quite work out.
No, but they still do that. Yeah.
So, well, they still do. I mean, I do it as part of what we do.
Yeah, one of many.
There is some utility to it. So the thyroid, so TSH, thyroid stimulating hormone, is generated in the pituitary, which is stimulated from the hypothalamus from thyroid releasing hormone. And there's like a negative feedback. So if you have enough thyroid in your circulating in your system, it will tell the hypothalamus to shut your thyroid down, and it will slow that down. When you don't have it, until there's not enough, and then it'll tell your brain to
ramp it up.
To ramp it up. So the number that you get is an inverse. Okay, and so if you have a high number, that means you're running low. if you have a low number running high. And I can't tell you, at least once a week, somebody will come in here and says, I got my lab test and it said it was running high, so I stopped taking it. Well,
Yeah,
and now
wrong
it's,
way round.
yeah, wrong way around. Okay. And I try to explain, but a lot of people
Mm.
don't listen. So the up until about 50 or 60 years ago, maybe 70, most thyroid issues were hereditary. It was from mom, dad, grandma, grandpa, usually on your mother's side. It was very rarely from any type of outside influences. In the last 50 or 60 or 70 years, I think the last count I saw was over 100,000 chemicals have been, invented and dumped into the world, and our bodies just can't handle it.
Mm.
It's just not handleable. Now, where I live, I don't know if it's, maybe I know more than I did, 15, 20 years ago, and I'm sort of acutely aware of it. But it seems that a third of the patients who come in to see me, new ones, don't know it, have some sort of autoimmune thyroid issue.
Yeah, yeah.
And I don't know, there's a lot of mining that went on around here. There still is. We're downwind from where the nuclear tests were done in the 50s and 60s. So, remember they were just,
Yeah.
setting off bombs all over, for a long while they were doing it in the air, and then they said, oh no, it's wrecking the air. We'll just do it underground, right? So
Yeah.
and we're sort of downwind from that. So I don't know, but it seems to me that and maybe it's just what I do, but there seems to be an awful lot of autoimmune issues here, especially thyroid issues. And then once you start with one,
Yeah.
it's a continue. They all come from the same place, so we just give them different names. If you have dry eyes, we call it Sjogren syndrome. If you have the thyroid issue, it's Hashimoto's thyroiditis. If you have if it's in your lungs and internal organs, it's lupus. So if it's in the intestines, it's Crohn's disease.
Yeah. So it's just
Or
auto. Yeah. We like to
but
label things,
it all comes from the same thing, and it's that
Mm.
our normal cells are fooled, and it gets misrepresented by things that look like it. And again, as genius doctors, like I mentioned about the low fat diets. Well, we go back earlier after World War II. Two events happened almost simultaneously. There was a scientific duo one was named Wolf, one was named Chekhov, and they did experiments with rats where they gave them radioactive iodine, which of course killed their thyroid, and they
Mhm.
extrapolated that to food grade iodine, and they decided that iodine was poison, and that's where the iodinophobia came from.
Yeah,
Okay,
right.
so
Right.
they convinced whatever was the FDA at that time to take iodine out of the food supply. That was
Brilliant.
number one,
Oh, well done.
right? Number two, and just to add insult to injury, was that the same again, big cities in the U.S. decided they were going to fluorinate water, put fluoride in
Yeah.
their water.
We've done that
Okay,
here
because
again. We're doing it
because
now,
yeah,
over here.
because it protects it, but it does protect against dental caries. But
Destroys your
unfortunately,
thyroid.
but iodine and fluoride are in the same chemical. If you ever look at a periodic table, the chemical table, they're in the same periodic classification. They're very similar. And when our body comes in contact with fluoride, it recognizes it as iodine until it realizes that it's not. And then it sends the cavalry out, which is our immune system, to go and kill it. Well, it kills everything. And if
It
you
was the
leave it alone,
thyroid. Yeah.
right? If you leave it alone, it'll take about 5 years. The thyroid, your thyroid's gone. And anybody who's had a totally destroyed thyroid knows it's a difficult and miserable thing to have to live with.
Exactly. And we do it on a population-wide basis here. We stick it in our
Right.
drinking water
And
still.
if you're only looking at TSH,
Mm.
I have another video. I actually have a patient when I did she came in here for 10 years. She was she was schizophrenic. She was in and out of psychiatric hospitals. She was doing antisocial things. We'll just leave it at that. She was disrespecting her family. We'll just call it that. And she came in here for Botox, actually, because I do that stuff too. And so I'm just asking her some questions because there's certain things there's certain characteristics that you can see. So the edges of the eyebrows, if you have low thyroid,
Yeah.
will
We'll
come
fall
out,
out.
and she didn't
Mm.
see there. Her
Mhm.
fingernails were kind of cracked and broken.
Mhm.
And she had some white spots on her fingernails, which are
Mhm.
actually a zinc deficiency, which is you see in thyroid issues also. So I
Mm.
started asking her, the thyroid question. So dry skin, dry hair. I could see her fingernails. Did she have constipation issues, which was terrible? She said she, was gained weight and she couldn't lose it. She was tired all day long and slept 12 hours a day and was still tired. So, and she says, I've had I said, well, that sounds like a thyroid thing to me. Oh, I've had my thyroid checked and it's always been normal. So she brought
Mm.
me to the TSH. And so
TSH.
the number 0.4 to 4.5 is considered normal. And she was always, she had 3 or 4 of them and they were 2.6, 2.8, 2.3, perfectly fine. So we ran everything. We ran
Yeah. The full panel.
we ran the full panel. So a T3, which is the parts that's usable, and we ran the free T3, which is the part that is not bound to protein. So hormones, when they're produced, are bound to protein, and even though you could have a lot of them, a lot of hormone, but if it's bound to protein, it's inert. It doesn't work. We need to know what the ERT part is.
Yeah.
Okay.
Yeah.
Usable part. And we ran a free T4, which is the store unit, and
Reverse
we
T3
ran the
and
thyroid antibodies, and
antibodies.
the thyroid antibodies were unmeasurable. It was
Wow.
greater than 2,200 on one and
Wow.
greater than 3,000 on the other, unmeasurable.
Very sick.
So I said, well, I think this looks like your problem here, right? And her TSH is 2.46, so
Wow.
um, so we, she slowly came around. So we use plant sterolins, which are the fat from plants. They actually act like Pac-Man in your system and kind of gobble up the antibodies. Depending on where you start, they either work quickly or not. So and again, depending on which lab, there's 2 main lab sort of arrays. One has a normal number of 9. Remember, I told you this lady was greater than 3,000.
Yeah.
And the other one has greater than 34. So if we're on the 9 scale and you're at 11, we jump on that right away, because if we leave it alone, we know what's going to happen.
Wow.
Almost somebody comes in and they don't know it. It's usually 200 to 400.
Wow.
And
Yeah.
my world record is 4,226 on the TPO. And that was a
Wow.
guy, he's still with me. It's been 8 years, 9 years now. Last time we did it, it was 101.
Wow.
They go to the
Huge.
the endocrinologist. There's nothing, it doesn't matter, and there's nothing you can do about it. Well, that's not true. And it does matter.
It
And
definitely
we tell them,
matters.
so yeah, so gluten, they're extremely sensitive to gluten. So the protein made from fake wheat.
Mm.
So we emphasize it. I can't follow them around, but we emphasize it over and over again. A strict gluten-free diet. We do
Strict.
you have Judge Judy there where you are?
Have
Judge
judge.
Judy,
Oh yes, yes, I've seen
Judge
it.
Judy, right? It's a Judge Judy deal. It's a yes or a
Or a
no.
no.
Not a little bit. I did it 80%. I did it 80.
Yeah.
No, it's a yes. Either you did it or so that's a
The,
no, right?
the gluten
85%.
must be
No.
completely gone. And gluten is a molecular mimic of, so this is why the autoimmune goes after dairy, gluten, and what's the other one? There's one other one. That are common. Casein.
Yeah,
Yeah.
the proteins, it's rye, wheat, and trilicate is a combination of rye and wheat.
Yeah.
But so we usually recommend white flour, white sugar, dairy. Those are the bad guys.
Off the table if
Yeah.
you've got Hashimoto's.
We have a computer program. We send patients recipes, menus, and they get it every day for a gluten-free diet. Probably about 60 days in a row. They'll get different recipes, menus, shopping lists, food pantry
Wow.
lists. So we really emphasize that, and that's one of the good things about computers. We can, it's an aid for us. So it does save us quite a bit of time.
Yeah.
Then we use the plant sterolins. That's usually our next line of work. And a lot of these people, their thyroid function is normal. Their normal thyroid free T3, that's the part that does the work, is 2.0 to 4.4. We want it in the 3.2 to 4.4, 4.2, the up at least upper half and upper third. That's when the patients will be feeling good. So, and then when I do my thyroid lectures, I always start with this. Okay, let's say we're at a white. So next week I'm going to be at the Nevada Osteopathic Medical Association. I call it the white bread medical guys. They're strictly by the book, right? They don't want to hear any of it. So here's your thyroid lecture. If the TSH is greater than 10, remember the higher that's a high number. That means you're low. Give them Synthroid. If it's 4.5 to 10, and they have symptoms, so that dry skin, dry hair that I mentioned, then give them Synthroid. If it's under 4.5, they're crazy. Send them to the psychologist. Okay,
that's their approach.
That's it.
Wow.
That lecture's over. Right?
That's so wrong.
That's nice to know, but there's nothing you can do about it. Okay, so and I mean it's just not so.
No.
And when you do it over and over again, there's 5 or 6 big triggers for autoimmune thyroiditis. The reason we emphasize hypothyroid, low thyroid, is because it's 98% of the time that's what it is. And usually by the time they get to us, if they've had a thyroid storm where they had like wild, crazy, palpitation in the hospital, psychiatric breaks. Usually that'll last a couple of months if it's untreated. And then they have a crash, and then they become hypothyroid.
So it goes from one to the other.
By the time they get to us, it's usually that's usually what it is.
And you had a good analogy. You said something like your thyroid is your gas pedal, and it is your gas pedal. So if it's foot to the floor, you're burning up through things, and if you're not. Yeah.
So one of the first questions I asked patients will come. I've had thyroid problem for 30 years. I'll say, okay, what does the thyroid do? And you'll get all sorts of answers. I say you get in 4 words, and the first 2 are "it's your," and you already mentioned it. So it's your gas pedal. That's what it
gas
is.
pedal.
And the light goes on. Okay, so this is our energy. This is our fuel, right? You too much, you're going to be you're going to be speeding until you can't, until you crash.
Yeah.
Not enough, you're going to be dragging around, right? And that's what it is, right? And then so the TSH, our boogeyman, that's our detective. It detects how much is in your system. If you don't have enough, your brain's going to tell you to make more. If you have too much, your brain's going to tell you to make less. And so that number that you get is an inverse. The high numbers means you're low, the low numbers means you're high. The part that does the work, and there's 4 thyroid molecules that are produced, 1, 2, 3, and 4. The numbers are the number of iodines attached to a protein called tyrosine. So if you ever buy like a thyroid supplement, it'll always have tyrosine in it. That's the
amino acid.
The protein that it makes it. The numbers, it actually makes 1, 2, 3, and 4. Synthroid or levothyroxine, the gold standard, is only T4. It also makes calcium, and there's a need for magnesium for it to function properly. So there are some synthetics, and one of the best one we can't get anymore, that actually has some calcium and magnesium in it. And so that's one of the side effects of Synthroid or levothyroxine is long-term use is osteoporosis. You lose calcium, you lose bone. Well, it's because you're not replacing it. That's why it happens. That's why that happens, because that's what the thyroid makes. The thyroid makes that.
Wow.
That's part of it. So we do the free T3, the free T4. There's also something called reverse T3.
Yeah.
Which is a three iodine molecules, but it's upside down. And that happens when there's some sort of inflammatory process going on, some sort of disruption. 90% of the time it's from cortisol dysfunction. It could be higher or low, but it's a cortisol dysfunction, and it's thyroid that's not usable. It's inert.
Yeah.
Now, if your doctor orders a T3, a total T3, and you get a number that's normal, you don't know whether it's that reverse T3 or the usable part. We don't know. I mean, if the number's high, well, then you can guess that, it's high, but again, you still don't know which one it is. So you really need to cone down and get the reverse T3 and the free T3.
So how can we get
The
this reverse T3 to come down? Because I was seeing that pattern a lot, right? You see this high.
Okay. So yeah, so for the most part, 90% of the time, the reverse T3 is actually a reflection of cortisol or stress hormone abnormality. So we go through that sort of chain of
Work up.
events.
Yep.
I used to, I don't do it as much anymore. I used to do that 4-point cortisol test. You do that one? Where
Yep.
they have them
Yep,
spit
we do.
4
Yep.
times a day and those graphs.
Yep.
Well, the reverse T3 is actually a pretty good check on that. And
Yeah,
that'll give
I learned that from you. I had never heard that before.
yeah,
That
yeah,
was related.
and
Yeah.
that's pretty good check on that. So we'll start if that's high. So normal on that is on our lab is about 8 to 25 is normal. But we'll start seeing symptoms, cortisol abnormality symptoms, when the reverse T3 is over 15 for the most part. And again, that's the reason we have the patients here. We're not just looking at numbers and saying, okay, you have to do this. I mean, that would be a lot easier, but
Yeah.
but that's not what you're supposed to do, right?
No.
So symptoms there, especially when the reverse T3 is over 15, are things when you wake up in the morning, you're tired. In the middle of the morning, you need something to keep you going, a coffee or tea, or I don't know if you guys got Red Bull there, but you might have some stimulant.
Unfortunately.
In the afternoon, the patients need a nap, or they take naps. By dinner time, they're exhausted. Later at night, they get a second wind, and that's when they're most awake. 8, 9, 10 o'clock, and then they have trouble sleeping. And there's usually sugar or salt cravings with it. Okay. Couple of other symptoms. There's something called a sergeant's white line. Have you heard of this? Where you have the patients lay down, and I use this the back of like a percussion hammer, or you can even take a pen and just run a line from the top of their pubic bone to the belly button, and it should turn red. And it should dissipate for after a little while. But if it stays after 2-3 minutes, that's a positive. That's only positive about 25% of the time. The other thing that you might sign, if you shine a light in the patient's pupil, they should contract. If they don't, if they dilate, that's also sort of a cortisol abnormality also. So those are things to look for.
Wow.
And it's pretty accurate. I mean, we correlate it probably 90% of the time, and most of the other time it's if their blood sugars are abnormal, which is also an inflammatory issue anyway. And sometimes if they've had just recent acute injuries, but for the most part it's a cortisol abnormality. So that's sort of how I separate it out. Symptom wise, thyroid patients, fatigue is constant all day, and the cortisol it comes and goes. They wake up tired, they get a wind, then it comes back again, then they get another wind, and it comes and goes. So
wow.
And
so you'd be every thyroid patient, or even you suspect of thyroid, you'd be also doing this cortisol, looking at the cortisol. Do you also look at the microbiome or anything?
That comes next. That's like sort of like the second.
The third leg. Yep.
Yeah. So, but unless it's obvious, they come in and they have all sorts of dysbiosis and they've had it for years, and yes, and then we'll go for it. But if it's not obvious, again, those tests are expensive. Insurances don't pay for it. So we try not to spend their money unless we really have to. So and a lot of times we kind of pick out a lot of the things anyway. And after you do this a while, as you start to recognize patterns. They become fairly obvious. Sometimes you're fooled, but not not often. So I mean, I'm not going to be able to tell you what parasite or bacteria you have that's off in the microbiome, but I can tell we can start probiotics, prebiotics. We can have them use fermented foods. We can do a lot of the things that you do. I'm certainly not going to give them antibiotics or antifungal agents unless we have that in hand. But a lot of the sort of practical things. And so let's go back to thyroid again. Remember so cruciferous vegetables, your broccolis, kales, cauliflower, which are good for if you're postmenopausal, because they have
sulforaphane. Yep.
Right. But for thyroid, It's the opposite. It actually slows the thyroid down. They have what are called goiter.
But this is only at higher levels, isn't it? Yeah. So, because I've been taught that the cauliflower, the Brussels sprouts and broccoli and so on, only are really problematic in really massive doses, and that they're okay on food level doses. You don't agree?
We've sort of come to the conclusion that one, they're usually okay if you cook them, so you shouldn't have them raw. So I don't know who's going to have raw Brussels sprouts.
Not really.
Sweet potatoes are on that list. I don't know who's going to have raw sweet potatoes. But again, I'll have patients who come in and say they have a spinach salad every day, and and they have thyroid antibodies off the chart. Well, maybe if you could, and again, it's not going to cure anything, I don't think, but every little bit helps. So if we can slow it down to 3 or 4 days a week, that would probably be a help. So every little bit,
and working with now, Dr. Bill, we've got so much more to talk about. I think we need a part 2 for this. I would love to do a deeper dive next time if you have time for me. Into the hormones. I want to look at growth hormone and all the sex hormones, the testosterones, those things for men and for women, and maybe dive deeper into there. So I think we need to do a part 2 if you're up for it.
anytime.
And where can people find you? So YouTube, everybody go and subscribe to Dr. Bill on YouTube, because
YouTube, Clearfield Medical Group.
Clearfield Medical Group.
Right, on YouTube. Our website is drclearfield.net. It's not .com, because some joker decided he was going to take it before
he beat you to it.
Tried to sell it to me for $10,000, and I told him to forget about it.
Yeah.
So .net, drclearfield.net. We also are aosrd.org, and you can find all of our integrative medicine seminars going back. So we've been doing this since 2020. We're there every Tuesday. I've only missed one in almost coming up on 4 years now.
And I want to join that. I want to join that and be a part of it. Unfortunately, it's in the middle of the bloody day in New Zealand when I've got clinic and things. But can we get the recordings if we can't make the live?
That's what I said. aosrd.org/webinar.
Right.
They're all there. They're all there.
Yeah. And I would love to share on there at some point, because I think, there's so much. I think that's a great group. I love the people on there. I've learned lots already
and we're really expanding we have a whole group of Filipino doctors now.
Wow.
That joined us. So we're really happy. And actually, one of them's actually going to be presenting this week. So this is the first time we're getting one of our new Filipino friends to present. So,
I'll try and make it.
Just to give you an idea. So this week, I don't know if you know that there was a new omega-3 has been discovered.
Fatty 15.
Yeah, that's what we're going to talk.
This week. I definitely have to listen to that, because Fatty 15, I've had that in Mum's protocol, and I've been trying to reach out to them and get it down here because I want to import it, but they don't respond to me, unfortunately. I had them on the show once as well, but there's some pretty powerful research coming out about Fatty 15, so very excited about
it. So that's this week, and we've had a lot of the leading lights in integrative medicine and anti-aging medicine. James Bell, I don't know if you know him. And
I've had Jim on. Yep.
How about Jacob Teitelbaum? He was the father of chronic fatigue syndrome. He wrote about chronic fatigue in 1975.
Wow. I've heard of him, but I haven't met him.
Yeah, I mean, these people, command $20,000 to give a talk for an hour and a half, and we have them on for.
So. I know. Like, there's some amazing people, and check out Dr. Elizabeth Youth, because she's my favorite doctor in the entire world. You should get her on if you can. I mean, she's a busy lady, but
all right. You get me. We'll get it off.
Get your connection. She's good. She's good. You'll love her. Okay, Dr. Bill, thank you so much for your time today. It's been an absolute pleasure.
Okay, thank you. I've had a great time. So.